It's my pleasure to introduce Dr. Ponce Martinez, who will introduce today's speaker. Dr. Ponce Martinez is the Chief of the Addiction Psychiatry Section, Director of the Addiction Psychiatry Fellowship Program, and Director of Telepsychiatry. Dr. Ponce Martinez.
Good afternoon, everyone. It's good to see everyone here after my leave. So I'm presenting today Dr. Rajat Duggirala. He is our current Addiction Psychiatry Fellow. Dr. Duggirala completed his undergraduate degree medical school and psychiatry residency at St. Louis University. While in residency, he led a diversity, equity, inclusion subcommittee and was later a recipient of the SAMHSA Minority Fellowship Award. He also served as a chief resident during his final year of residency. He was recently awarded the John Renner Travel Award to participate in the annual meeting of the American Academy of Addiction Psychiatry. His academic and research interests include cultural psychiatry, addiction-related mortality, and physician wellness. Please join me in welcoming Dr. Duggirala as he presents on this important topic.
Thank you, Dr. Ponce, for a kind introduction. I'm glad to be here. Today, I'll be talking about addiction through the lens of race and trauma. This is something that has been very relevant in my training so far, and I hope it carries some value for you as well. I have no relevant financial disclosures or conflicts of interest. So to start off with some objectives, I'll first be going over the historical and cultural context leading to treatment disparities within substance use. Next, I'll talk about the cycle between trauma, incarceration, and substance use. And that in itself can be a manifestation of culture or a function of culture to some extent. And finally, by the end of this lecture, I hope you can apply some different tools to provide culturally sensitive and trauma-informed care. So to start off with a brief history, in the 1800s, opium was commonly used, especially within Chinese neighborhoods and Chinese immigrants. Opium dens is what people resorted to, which were hidden places for people to smoke without social consequences. They were very popular in San Francisco and run by Chinese immigrants, but open to all. However, as time went on, opioid addiction grew. There was also lots of anti-Asian sentiment that grew as well. And that led to the first 1875 anti-opium ordinance in San Francisco, which made it a misdemeanor to keep, maintain, or visit any house or room where opium is smoked. So it functionally criminalized certain neighborhoods or parts of neighborhoods where Chinese immigrants would often frequent or live even. And this in itself kind of set this precedent that enforcing addiction can be tied to racial discrimination. Later in the early 1900s, this was the title of an article that was actually published in the New York Times. It's actually authored by a physician, and it specifically talked about Black Americans who use cocaine can incite homicidal attacks, they have deadly accuracy, and they're resistant to the knockdown effects of fatal wounds, so functionally immortal, and created this racialized panic and rhetoric in the United States. Not too long after, the Harrison Narcotics Act in 1914 was passed, which made it possible for the government to regulate production, importation, and distribution of opium and coca products. It should be noted that when the government was trying to pass this, they were trying to improve trade relations with China. However, South states were opposed to this. They preferred state rights, but as racially charged panic grew across the country, acts like this were more easily passed. And not too long after was the alcohol prohibition in 1919. And so there was a huge nativist sentiment as well as a progressive era. And the Marijuana Tax Act of 1937 allowed for the taxation and regulation of marijuana. The Mexican Revolution was happening around that time, around 1910, and as more Mexican immigrants and refugees were coming in, fear of marijuana use, especially within the Mexican immigrant population, grew. Looking at the 1970s, so a lot of different things were happening at this time. There was the counterculture movement, a war in Vietnam, HIV epidemic, so people were using drugs more frequently. But there was also just this overwhelming fear of a drug epidemic. And one poll even suggested that about 48% of Americans using 48% of Americans thought that drug use was a serious problem. And at the time, Richard Nixon, he used this as one of his platforms. He said drug use was a national emergency, public enemy #1, and he declared a war on drugs. 2 years later, the DEA, or the Drug Enforcement Agency, was created. And in the 1980s, this was the start of the crack cocaine epidemic. Notable in that time was the Anti-Drug Abuse Act of 1986, which aimed to put mandatory minimums on illicit drug use. So penalties for crack cocaine at the time, and crack is the rock formation that can be smoked, were 100 times harsher than for powdered cocaine. So it was not equal by any means under this act. And so what that means is, for example, possession of 5 grams of crack cocaine triggered a 5-year jail sentence, but for powdered cocaine, you would need 500 grams to achieve that. And it should be noted that crack cocaine was far more prevalent among Black communities, and 85% of those sentenced for crack cocaine-related offenses were Black. Later, over time, the Obama administration actually changed this disparity from 100-to-1 ratio to about 18-to-1 ratio. But it framed this idea that this is a criminal issue first, and then it's a public health issue. This is also the time that we started seeing mass incarceration. Even currently, United States has one of the highest incarceration rates in the world, with Black men 6 times more likely and Hispanic men 3 times more likely to serve time. Even for something like cannabis, where use rates can be similar, Black people are 3.5 times more likely to be incarcerated for cannabis-related crimes than their white counterparts. Finally, in the late 1990s and 2000s, beginning in 1998, this is when we first saw a decrease in white life expectancy. This was 2 years after the FDA approved OxyContin as a minimally addictive pain reliever. And this was also around the time that the American Pain Society talked about pain more, utilizing pain as a 5th vital sign. And this was also supported by the Joint Commission. Drug representatives were also being sent to largely white states, so more and more people were becoming dependent on opioids. During this time, 2 years after, the Drug Addiction Treatment Act of 2000 was created. And although there was methadone and methadone clinics, expert testimony that actually helped get this passed talked about how it was inappropriate for suburban users to use methadone, and it's basically inappropriate for the suburban spread of narcotic addiction. Even 3 years after the Drug Addiction Treatment Act was passed, some data shows that up to 91% of people who were getting prescribed buprenorphine were white, college-educated, and dependent on prescription opioids. And so this bottom left picture here is a screenshot that I took from the National Alliance of Advocates for Buprenorphine Treatment. I thought it was very ironic, the picture that they used, given the data that we're seeing. October 26, 2017, almost 20 years after we saw the decrease in white life expectancy, the opioid epidemic was declared a public health emergency. And now, around this time is when we started seeing a cultural shift, going from, especially as more white and rural populations were being affected by addiction, there was more of a shift in public perception towards recovery rather than punitive measures. So now talking about current outcomes and treatment disparities and what this all really kind of boils down to. I'll start with the nation on the national level and get more specific to the state, and then down to Worcester as well. So when we're looking at nationwide disparities, substance use disorders are actually equivalent among white, Latinos, and Black communities. However, American Indians or Native Americans have the highest rates of substance use disorders and the highest drug-induced mortality. The pictures on the right are overdose deaths per 100,000 people across all substances, and they're both from the CDC. The top picture is from 2019 to 2020, and you can see that the overdose rates are highest and increasing in the Black and American Indian population, then white population and Hispanic population. 2021 to 2022, the blue bar being 2021 and the green bar being 2022, it is increasing in overdose death rates are increasing in all minority groups except white and Hawaiian or Pacific Islander groups. And I mentioned buprenorphine differences already, but I did want to say even currently some data shows that Black people can be up to 77% less likely to be prescribed buprenorphine. And this can partly be due to access. Only 60% of US counties have an outpatient substance use treatment center that accepts Medicaid. But even in studies where they adjust for access, adjust for socioeconomic factors or criminal justice referrals, Black, Latino, and American Indian clients are less likely to engage in treatment. And this is particularly true with Black adults as well in even treatment entry and completing treatment programs. So now looking a little more closely within Massachusetts, how is Massachusetts doing compared to the national level? So Massachusetts ranks 33rd among all states when it comes to overdose deaths across all substances, 50th being the worst. This is surprising because it also has the lowest uninsurance rates and also has one of the highest per capita spends when it comes to healthcare costs. And this is from the Massachusetts Bureau of Substance Addiction Services. But obviously, opioids are a big issue with 90% of opioid overdoses, including fentanyl. And the BSAS services, they also identified areas where people are more likely to die after using and named it hotspot clusters. This includes Worcester, Greater Springfield, Western Mass, and Southeastern Massachusetts. When we look at opioid-related overdose rates, so again, per 100,000 people, this is a breakdown by race within Massachusetts from 2019 to 2023. And you can see that it had steadily increased and then decreased from 2022 to 2023. This is the largest single-year decline since 2009. And you can see the same narrative in the white and Hispanic community with a decrease since 2021, but in all other minority groups functionally increasing over time, with Black community almost doubling since 2021. And I didn't want to gloss over the Asian community because although it's low, it's almost doubled since 2019 as well. And of course, the American Indian or Native American population, I mentioned before that they have the highest rates of drug-induced mortality, and that's seen here within Massachusetts as well. And the volatility is something that kind of stuck out to me as well. When we talk about overdose deaths and treatment, it's important to talk about access as well. Again, this is from the Bureau of Substance Addiction Services in 2023, and this specifically looks at the number of OTPs compared to the fatal opioid overdose rate. So for example, Worcester has 9 OTPs or opioid treatment programs and has an overdose rate of 31.9, which is slightly higher than the state average below. These numbers here talk about what % of the population is captured within a certain radius, either driving or walking to an OTP. And so my big question with this chart was, is there a relationship between the number of OTPs and the fatal opioid overdose rate by county within Massachusetts? So I made these two charts, or these two graphs. The blue bars are the OTP counts, and the red line is the fatal opioid overdose rate. And the long and short of it is that I couldn't find necessarily a relationship or a meaningful one. For example, Bristol and Essex have very similar OTP counts, but the overdose rate is very different as well. And same with access. Blue bars being 15-minute drive access to an OTP and orange bars being a 30-minute drive to OTPs. And you can see almost all counties in Massachusetts have about 100% capture of the population to an OTP within a 30-minute drive. But again, it does not correlate very obviously to fatal opioid overdose rates. I did want to mention before I move on that Worcester, again, has one of the highest OTP counts with good access. It also admits more individuals to BSAS services and prescribes almost double the buprenorphine or naloxone compared to other counties. But still, we are seeing a slightly higher than state average fatal opioid overdose rate. In Worcester, more specifically, these are the demographics as according to the United States Census Bureau in 2023. It's 58% white. And this is the number of deaths from 2019 to 2023. And you can see it's not surprising that it's highest in the white community, which are these yellow bars here, but has gone down in the minority group and the white community from 2022 to 2023. Same when you look at the death rate, or per 100,000 residents, highest in the white community. However, if you change the perspective just a little bit and look at it as percent of deaths within a community, you can see that the narrative changes a little bit. So what that means is that, for example, in the Native American or American Indian population in 2023, 60% of all deaths in 2023 were attributable to substances within the Native American population. And overall, minorities do have a higher percentage of death related to substances compared to the white community, which is the yellow line down here. And looking at opioids in Worcester, again, has decreased in the minority community from 2022 to 2023. And that is different from what we saw on the state level. The death rate is actually highest in the Hispanic community. And again, when you break it down as percent of deaths, you can see that the percent is higher within minority communities as well. Not to beat a dead horse, but it's a similar narrative within alcohol as well. And you can see that the percent of deaths can look very different when it comes to minority communities. So that's kind of my big takeaway from looking through all this data through the Bureau of Substance Addiction Services, is that the percent of substance-related deaths can be higher in minorities. And so the burden of disease is not equal necessarily. And this is not too dissimilar from what we saw on the national and state level as well. And so the big question is, why does this occur? Like, what are we missing here? You know, I've talked about a few things already: legislative policy, mass incarceration, access, engagement, and treatment. And my big thing here today is to propose that culture and trauma can play a big role and can be key factors when it comes to addiction treatment. And it's been very relevant in my training so far. So I wanted to go back and give credence to culture and trauma and how that can play a role for just a second. So I'm from suburbia, Illinois, but I trained at St. Louis University. And so the demographics of St. Louis can look very different. 43% Black, 44% white as of 2020. The picture on the left is a depiction of the poverty concentration, with orange being the highest. And the picture on the right is the concentration of the African-American or Black community on the right, orange being the highest. And you can see that the maps are almost superimposable. St. Louis also has some interesting like community or population level dynamics. So, that is where I trained in St. Louis right there. But I wanted to mention the Del Mar Divide, which is something that we often learn about in St. Louis. This is a remnant of Jim Crow era laws. This is Del Mar Boulevard right here. And you can see above it, the home value is very low. It's 99% African-American or Black population. And below it, you can see much higher home values, higher education rates, access to good care, access to health care and nutritious food. And it is, when I've driven down this street before, you can look on one side and the other, and it juxtapose the two sides. So it's quite remarkable. And so I was noticing this within my community, and I was wondering, is this happening within my own hospital as well? Is this happening in our own psychiatric department as well? So about halfway through residency, I did this quality improvement project with a couple other residents. We have 2 psychiatric units in St. Louis. One's an acute psychiatric unit for agitation, psychosis. It's more heavily staffed. There are security guards there. We also have a subacute unit, which is for milder symptoms of depression, anxiety, or withdrawal. And the big question that I had was, is there a difference in race distribution among admissions to the acute and subacute psychiatric units? We collected data for 3 months. We did a presentation to the faculty and residents, and with no recommendations on changes in policies or procedures. And then we just did a recollection for the next 3 months. And this is what we found. So in the fall, we found that 63% of all patients admitted to the acute psych unit were Black, 28% of those being diagnosed with schizophrenia. In the spring, after we did the presentation to faculty and residents, we found that a quite remarkable reversal. 36% of all patients admitted to the acute psychiatric unit were Black. 15% of those being diagnosed with schizophrenia, and the number of white patients on the acute unit diagnosed with schizophrenia increased remarkably as well. The other things that are not depicted here, the number of hospital emergency codes for agitation or elopement decreased almost tenfold, and the length of hospital stay also decreased by about 10 days. I very much recognize that this is only 6 months of data, and so it would have been very interesting to extend this out further. But it showed me that, maybe implicit bias or the culture of our program is playing a factor when it comes to diagnosis and treatment. But beyond that, education can make a difference, and disseminating that information can definitely make a difference. So this was about halfway through residency, and I wanted to know, is there a way I can better engage with my patients? And accommodate the fact that there is implicit bias, or the fact that the treatment population doesn't look like me or my co-residents. So towards the end of my residency, I aim to do some cultural interviews with patients at an opioid treatment program in North St. Louis through a church called Jubilee Church. And North St. Louis is about 97% Black. And the first tool that we utilized was the cultural formulation interview per the DSM-5. If you're not familiar with this, it is 16 questions across 4 domains. So that might include the cultural definition of the problem, perceptions of cause, context, and support, factors affecting past self-coping and past help-seeking, and then factors affecting current help-seeking. And if you're familiar with the CFI, people often think of it as supplementary or additive to a traditional HMP, but this chart here shows that it can very much replace some of the questions that you would normally use for a traditional HMP, and can be very insightful. The second thing is the UNREST tool, or the Yukon Racial Ethnic Stress and Trauma Survey. So I noticed throughout my residency that there was a lot of trauma in patients, and there was a lot of distrust. So I wanted to see if I could have a tool that would help me elicit some of those narratives a little better. And this was published in the American Psychological Association in 2018 by the University of Connecticut, with the purpose that PTSD related to racism is likely underdiagnosed. And that is the point of these 11 questions, is to hopefully uncover some of that racially charged trauma. This picture here is from that article, and specifically talks about how things that are happening on the society level, like cultural issues and later invalidation and institutional racism, can convert feelings of distrust or anger into emotions like hyperarousal or hypervigilance or avoidance, things that we normally associate with PTSD. And so I'm not going to go through all of the questions, because that would take way too long, but I will talk about some of my favorite questions through both of these surveys, so you have a little bit of a grasp of what I'm talking about. So instead of asking questions like, what brings you here, the first question might be, sometimes people have different ways of describing their problem to family or friends. How would you describe what's going on to them? The second question being, are there any aspects of your background or identity that are causing other concerns? Third question being, often people look for help from many different sources, including different kinds of healers or helpers. In the past, what has helped you? And this is probably the question that I use most frequently. It's sometimes doctors and patients misunderstand each other because they come from different backgrounds or have different explanations. Have you ever been concerned about this? And all of these questions, I've gotten very varying responses, especially with self-coping in our acute psych unit. I remember one family even telling me that their son doesn't have schizophrenia, that it's a spiritual disease and he needs to be dipped in olive oil. So it's very hard, as you can imagine, trying to engage with family and having them rally behind this patient, and when it comes to my perspective, which is the medical model that I was trained in. The UNREST survey, some questions include, what sort of things, positive or negative, did you learn about your race and ethnicity growing up? Many people talk about how it can be difficult to be part of a minority. Have you ever wished you were part of a majority group? And finally, can you share with me a time you were impacted by racism? So I picked two narratives from two patients after doing this project. First patient talked about how he got high with his dad as a form of bonding, and he was very distressed by Michael Brown's passing. And if you're not familiar with Michael Brown, this was an adolescent 18-year-old Black male that was killed by a white police officer back in 2014. This caused a lot of social unrest within Ferguson, Missouri, where this happened, which was pretty close to St. Louis, Missouri. It did make national headlines as well and continued the Black Lives Matter movement at the time. But he also talked about using drugs and opioids as a means to hide pain. He talked about personal safety, being aware of his race since birth, and relying on God to stay strong and stay prayed up. So even these 3 points in itself are pretty dense. We know why he uses, we know what age he started using, his relationship with God and religion. And we also learn about like this deep distrust and hypervigilance he has on a day-to-day basis that leads him to continue using. And at the end, he did say, if only all doctors did this, implying that it was very meaningful for him and he was able to have a meaningful connection. And then patient number 2, she talked about having lots of physical abuse from her father, felt a lot of pain, irritability, and fear. And this led to marijuana use, heroin, and fentanyl use later in life. She also talked about specifically being called the N-word at 12 years old when she was at a pool party. And this led to feelings of rejection that she felt constantly that led to drug use. I noticed as I was doing these narratives and talking with these patients, I felt the tension kind of ease immediately, like a wall was coming down. But also I was asking questions in a way that I wasn't asking before, and I was getting some information that I wasn't getting before, especially when compared to like a traditional H&P that I would do in the hospital. So to conceptualize everything that I'm saying in a little different way, we often learn about structural determinants of health and how that impacts either incarceration, mental health, or substance use. And you might have seen this before with, the individual being nested within interpersonal community and society level dynamics. And I'm sure we've all learned about adverse childhood experiences before. And the statistic is that 6 or more adverse childhood experiences can lead to about a 46-fold increased risk of substance use. The project that I did was actually replicated similarly within the Massachusetts State Prison. And what a group of researchers did was they conducted open-ended interviews with about 30 prisoners, half male, half female, half black and Hispanic, and half white. And the goal was to add on to this conceptualization or this framework about structural determinants of health and how that can lead to substance use. And so they took it a step further, and it's very similar where you have the individual nested between interpersonal community and society level dynamics. But they also talked about after people develop a substance use disorder or a mental health issue, why it leads to criminalized behavior based off of these interviews with these inmates. And most often it's to obtain money or due to impaired judgment, which can lead to incarceration. But they also talked about how release after incarceration kind of puts them back in this same systems that haven't changed. So it creates this cycle or loop that people get stuck in. And I want to remind everyone that the propensity to fall into this cycle is not equal for all. So from 1970 to 2010, like I mentioned, this was an era of mass incarceration. Even currently, Black and Hispanics make up about 56% of the prison population, which is not reflective of our society at large. And not only are substance use disorders placing a higher burden on minority communities, but getting caught in this cycle can make it much harder to break away from the cycle as well. When we're talking about breaking away from the cycle, they did ask inmates that as well, and they identified a few themes that I wanted to go over. So on the society level, they talked about having continuous services, so services that start before imprisonment, continue during imprisonment, and after as well. And they wanted to build long-term relationships with their providers. They also talked about, on the community level, having religious services or having connections to their churches, especially when some of the inmates were gang affiliated previously, and that was their source of connection. So it was helpful to see that narrative as well. And on the interpersonal level, they talked about wanting prisons to be less hypermasculine, more trauma-informed, And on the individual level, they mentioned things like stigma and isolation. I wanted to point out here that isolation was a big theme across all of the different social determinants levels. And we've heard that before. We've heard about addiction being a disease of isolation, and that was certainly reflected in this paper as well. I wanted to add just another layer to that, which is that people can get caught in this cycle, but this can also be passed down to their children. And when it can be passed on through generations, we call that intergenerational trauma. And functionally, that very much reminds me of the definition of culture in itself. Culture, as per the DSM, is defined as a system of knowledge, rules, or practices that are passed down through generations. And trauma, I'm proposing, can also be passed down in a similar way. For example, incarceration of a parent does lead to increased likelihood for poverty and substance use within a child as well. Specifically within Black women, each increase in the number of parents or grandparents with substance use can lead to about a 30% increased chance of drug use, but also a 40% increased chance of having an open child protective service case with your own children. Again, perpetuating the cycle of disruption in the parent-child relationship. Even in when there was a study that looked at Black mothers with white mothers, and even though use rates are similar, Black newborns are 4 to 5 times more likely than their white counterparts to be referred to child protective services. So overall, increased likelihood of criminal justice involvement. And I would be remiss if I didn't talk about American Indian or Native American population. And it's hard to kind of broach this topic because the culture can vary depending on the region and depending on who you're talking to. But remember, use rates are high in this community, and especially in Worcester, in Massachusetts, nationwide as well, and drug-induced mortality is high. So I found this article, which I thought was very illuminating. But what they did was they did focus groups with tribal elders in the upper Midwest area, and they asked them, what's on your mind? They asked them to go over different topics that were important to them or their ancestors, and they've identified things like loss of land, loss of language, loss of culture, and they went they created this Likert scale, so asked people to rate them, their symptoms from 1 to 6. And they found that the higher they scored on the scale, the more likely they have feelings of sadness and anger, but more likely having symptoms of depression, suicidal ideation, and substance use. Down to the granular level that the higher they scored on this, the more likely that they used substances or drank alcohol within the past 30 days. So finally, talking about next steps and what we can do. So I mentioned the CFI, or the cultural formulation interview. I also mentioned the unrest tool, and those both can be very helpful. When we talk about substance use at large, what we're really talking about is like the context or the culture of use. You know, how does it affect your job, your family? And that context is different for everyone, whether they're part of the LGBTQ community or a racial minority group, or, you know, within their own family. It makes a huge difference. I wanted to speak to diagnostic accuracy as well. The CFI can help, especially when you're dealing with people that are from different ethnocultural backgrounds than yourself. There's actually a cultural consultation service in one of the hospitals in Canada, and they did a retrospective review of 10 years worth of psychotic diagnoses, and they actually reversed 323 of those diagnoses, specifically in people of different ethnocultural diverse backgrounds and often in refugee patients. So it can be very helpful. The other piece I wanted to add is that cultural competency and humility is very important. Their literature does show that there's a lack of education around this, especially within residency, but even something like a 1-hour didactics can really improve the quality of cultural competency within residents. And ideally, we would want this even before, during med school as well. And I'm sure we all heard about trauma-informed care. It has been shown that it can be very effective in increasing patient engagement, subjective experience of care, as well as providers' work satisfaction, which is not necessarily a metric that we often or readily think about. But the idea of trauma-informed care is that it's not necessarily a set of tools that you whip out when a patient with trauma comes in to see you, but it's rather the idea that it's a blanket sort of system that you incorporate all patients within. And what this might look would be like arranging furniture so patients have easy access to the door, minimizing forms prior to appointments, or even things like observed urine drug screens or IV blood draws that can be very difficult for some patients who have a history of IV drug use, for example. So being open to that discussion or having those discussions with patients can be very informative. And finally, some culturally focused initiatives. This is specifically within Massachusetts and Worcester. There's the recovery-based reentry services for Black and Latino men, as well as Legendary Legacies. These are two reentry and reintegration services specifically for Black and Hispanic minorities that have been recently incarcerated. And this picture here is from the reentry services for Black and Latino men, and specifically talks about community building activities, care coordination, and supported referrals. All to say that they are tackling isolation in a very different way. And I think that in psychiatry, we can all relate to that frustration sometimes of, maybe for this patient, I could prescribe a friend. And functionally, they're able to do that here. I also wanted to mention for Black-led recovery community organizations, there is a lack of Black-led RCOs, and that can be very helpful. Early data shows even up to a 50% success rate for Black individuals seeking sobriety when they have RCOs that are led by people that look like them. And it improves treatment adherence and reduces harm as well. For both of these, unfortunately, that there is a lack of funding, and that's something that we have to be mindful of. For future directions and limitations, so I mentioned education and discussion multiple times throughout my presentation, especially with my QI project, showing how asking questions can be important, but then discovering current practices is also equally important. And it matters how we look at the data and what lens and perspective we're using. I'm very much aware that other disparities or cultural factors exist, ones that I haven't talked about here today. For example, women have longer wait times for addiction programs. LGBTQ plus individuals have higher risk for drug use and drug-related mortality. And even on the society level, when we talk about culture, there are things like needle exchanges, contamination testing, safe injection sites, which can improve outcomes, decrease mortality, decrease the spread of infectious diseases, but is not necessarily readily accepted. And that's different based on where you live and what the culture can be. The second, I also wanted to talk about implicit bias as a cultural experience. So as residents or trainees, when we join a place, we often subscribe to the practices that are already being done there. It's not necessarily within our power or necessarily easily accepted for us to question these practices. The other thing is that residency does have high turnover. Every 4 years, you have almost entirely new staff. So my question is, as faculty or as trainees, do we have all of the information? What do our admitting practices or outcomes look like? And how frequently are we evaluating them? And this more specific education specific to each residency program or each area of practice would be very much helpful. And finally, that there is a huge gap in research when it comes to this. It's not necessarily easily monetizable. And there are a lot of region-specific variations, which makes research even harder because you're not able to generalize your findings necessarily. Especially for the American Indian or Native American population that I've mentioned before, there is a need for more research and why this is happening and treatment options as well. So just to reiterate my final points here, we talked about the social construct of race and how that can lead to the criminalization of addiction on the policy and legislature level. but that also does lead to racial disparities in treatment access and outcomes. And this can very much be cyclical and generational, like I mentioned. And this is some things that we can do about it, like research and education is very important, but using various tools for trauma-informed care and cultural sensitivity as well. And those are my references. Thank you so much.
Questions? Got some on Zoom.
Thanks so much for a great talk, and you covered a lot of ground and great QI project in residency. That was phenomenal. You tried to tackle some of the data in Worcester in terms of, we seem to have adequate access. We seem to have good treatment. What are some of your working hypotheses or ways that we can improve that outcome data using the tools that we have?
I think that's a really good question. And the long and short of it is I don't know. So I just moved to Boston or to like a few months ago, and then I just started at Worcester. And I'm still trying to get a lay of the land of like what is happening, what kind of practices that we're seeing. I did the Road to Care rotation. And so like people are coming in. I'm not sure where the discrepancy is between people do have access to care, but there's still overdose deaths going on. And like that includes the fact that there is much more availability of Narcan too. So that's a great question. I don't have a great answer to that.
Well, I had an idea, but this was really wonderful. Thank you for doing this. I was wondering about the access to intranasal Narcan and if that was impacting the overdose rates. And, I know we distribute Narcan in our emergency department. I wonder if there's any racial disparity in terms of like who we're distributing it to. Like, do you know if there are any data on who has access to bystander administered Narcan?
On the national level, I know that racial minorities are less likely to get medications for addiction, like buprenorphine, for example, but not readily for Narcan. And I would be very interested to see if like on hospital level, the ED, what that would look like too. Yeah.
So, you have a question?
I wanted to point out, thank you, Raj, for the wonderful presentation, and I think bringing a lot of awareness to us about this issue. I'll point out that the reason we have such specific data with Massachusetts is because we're actually able to draw data from pretty recent data regarding overdose deaths and that utilizes information from a number of different agencies and help us understand the opioid overdose epidemic in Massachusetts. And that's not the case for a lot of the states. And so this granular data, we can look at overdose deaths rate overall and say, we're doing such a wonderful job. The number is going down. And when we were able to look more granularly at the data, looking at racial and ethnic groups, we're really able to see some disparities. And so this idea of treatment access, it's great for the state. And I think a lot of it is predicated on the idea of if you build it, they will come. And so you have all these programs. But the truth is that not all groups are accessing treatment in the same way. Not all groups are staying in treatment in the same capacity. And I think that sometimes reflects our practices as physicians and as clinicians in general. Are we offering pharmacotherapy, which is the gold standard really in opioid in addiction treatment? Are we offering it in the same way to all of the populations? And so do you have any ideas as clinicians and something that you've seen perhaps in the different settings that you've practiced about how we can better address these disparities and to help reduce some of these treatment access problems?
Yes. So that's a big question. And I think the more granular data definitely helps. Some things that I've noticed in other places is like, and Worcester kind of does this as well, but going to the patients and meeting them where they're at. Oftentimes we, especially if we're working in a hospital setting, we wait for them to come when things are bad enough. But like, for example, in St. Louis, one of the opioid treatment programs was out of the church because patients weren't coming to see providers at other opioid treatment programs. But when they had their church leaders saying, hey, there's a doctor we trust, he doesn't look like us, but trust me, come see him, we were getting far more engagement. So I think that's part of the puzzle. But there's so many other things that go into how to reduce treatment disparities. Yeah.
Hey, Raj, wonderful talk. And I think it's eliciting a lot of really important and good discussion. I like the way that you talked about how trauma plays into substance use disorders, especially with the focus on intergenerational trauma. Do you think as we're helping patients, in clinic or in the hospital, we should focus more on like symptoms of PTSD and treating possible comorbid PTSD? Do you think that should be like one of the focuses of our even like initial visits with patients?
I think so. I mean, in my short time here, I've used it a lot in the ACTS clinic and even in the hospital setting. And I've noticed a lot of patients who do use do have some trauma. It's almost like I can count on the number on one hand the people who don't have trauma who are using substances. So I think it's very relevant. I just think that patients are not always ready to talk about it. Yeah.
So we have a question from online, and it said that you discussed the implicit bias in the diagnosis or diagnoses such as more schizophrenia being diagnosed in Blacks. It seems it's the same with the prescription of antipsychotics. Black patients with psychosis have a distinct pattern in antipsychotic prescription with less use of secondary generation antipsychotics, including clozapine, but more use of depot antipsychotics. Your thoughts?
That's very much supported by the literature. I think that's a great point. Black patients are also more likely to get restraints and more likely to be diagnosed with psychotic disorders compared to white counterparts. It's very interesting too if you go to different areas like countries that have more Black people in them. Their rates of schizophrenia are not too dissimilar compared to the white population here. So it's a complicated issue to untangle.
Yeah, and along those lines, there's an old study of the presentation of African Americans with psychosis, that they were more likely to be diagnosed with schizophrenia than what they really had, which was psychotic depression, which was more likely to be diagnosed in the Caucasians. Another question from online. Did you come across any research that spoke to the most effective ways that lead to the cessation of drug addiction, and specifically any research about the power of having a baby and leveraging both the baby's and the parents' plasticity as a window of opportunity for people with experiences of racism and trauma?
So if I'm understanding that question right, it's if we can leverage the fact that someone has a baby or children to kind of break out of the cycle of addiction.
Sounds like that's what they're asking.
Yeah, I mean, in practice, that's very much true. For a lot of people, they use, and their big motivator to stop using is the fact that they're pregnant, that they might lose the baby, or that they can turn it all around if they were to stop using.
Okay, this is the last question online. I was wondering what you think about treating addiction and addiction specialty services versus primary care or adult psych, and if this affects access. The questioner is a general adult psychiatrist who has not prescribed buprenorphine since they came to UMass in 2020, since these patients are triaged to the specialty setting.
I definitely think there's value in uptraining other general practitioners because you're right, there is a delay in treatment when the culture is that this has to go to a specialty. And so, for example, in St. Louis, the culture was not necessarily to give Suboxone or buprenorphine right away, or that they would have to follow up outpatient. And so it makes me think of all of the missed opportunities when we try, and of course, there's a place for specialties and specializations, but I think there is value in uptraining general providers as well.
And Dr. Hobart comments that in family medicine at UMass, every attending resident, nurse practitioner, and PA prescribes buprenorphine.
It's great.
Well, if there are no other questions, thank you very much. A very interesting talk. Thank you.